Assalamu alaikum. Today we are demonstrating a case of left adrenal mass. The patient is a 45 years old gentleman who presented to us with acute pain in the left flank, and upon examination it was found that his left flank was very much tender, and he had an episode of hypertension with tachycardia and all those things. And on ultrasound he was showing a mass of suspected hematoma in the left flank region at the upper pole of the kidney. And after stabilization and treatment and pain relief, etc., and admission, his CT was performed, contrast enhanced, and it showed an around 6.5 to 7 centimeter adrenal mass in the left side, and there was acute hematoma around this mass. His profile was performed, urinary VMAs and metanephrines, and it turned out to be Pheochromocytoma. So he remained admitted for at least 2 weeks or so with us for stabilization. He was given Cardiora as the phenoxybenzamine is not available nowadays. So we had to rely on the alpha blockers as well as the beta blockers to stabilize him, and his hypertension was also treated by the cardiologist. His echo, etc., were normal, and we had a plan. You can see that this is the gonadal vein after mobilization. So we had this thing in mind that with the hematoma, with so much inflammation around, it may not be possible to perform adrenalectomy early as well as laparoscopically. However, after 3 weeks of time, we decided to place the laparoscope inside and see what happens. And you can see here that the left-sided colon is being mobilized medially. We have exposed the gonadal vein, but you can see the inflammation around that area. It is really very difficult to differentiate where is the kidney and where is the adrenal gland, and all the gut is also adherent to it. This is the gonadal vein that we are going to follow. So we are going according to the principle. We have mobilized the spleen slowly and gradually, and we are mobilizing the left colon medially. However, yet the anatomy is not very clear. So looking at the principles of laparoscopy and robotics, safety is the first thing. And look at this moment when I'm touching the adrenal gland or the upper end of this mass, combined the kidney and the adrenal. The patient certainly develops hypertension with a systolic of more than 200 and a diastolic of more than 150, and there is severe palpitation. Even I can feel the aorta on my instruments. So now we have reached the medial aspect of this mass. However, it is really very difficult to identify any renal vein. Here we are dissecting the gonadal vein, you can see. This is the most probable area of the renal hilum. However, the renal vein cannot be identified. So if the renal vein is not identified, how can we identify the adrenal vein? And so you can see here the spleen is mobilized a little more, and as soon as I press upon this mass, because of the dissection on the spleen, the patient again becomes extremely tachycardic and hypertensive. So then even I decided to go for the mobilization of the mass rather than the mobilization of the vessels. But you can see that the distinction between the upper pole of the kidney and the adrenal gland is not really discernible. So in order to be safe for the patient, we decided to convert this case to open. Thank you very much for watching.